Metabolism depends on thousands of enzymes working in precise sequences. Each enzyme catalyzes a specific reaction, converting one molecule to another. When genetic mutations disrupt enzyme production or function, the entire metabolic pathway fails. This creates predictable patterns of disease based on where the blockage occurs. 3 consequences follow enzyme deficiency, and recognizing these helps you predict clinical manifestations. First, substrates accumulate before the blocked step. If an enzyme can't convert substance A to substance B, then A builds up to toxic levels. Think of galactosemia. Galactose-1-phosphate accumulates when galactose-1-phosphate uridyl transferase fails, damaging liver, brain, and kidneys. Second, accumulated substrates divert into alternative pathways, creating abnormal metabolites. These wouldn't normally exist in significant quantities. In phenylketonuria, phenylalanine can't convert to tyrosine, so it transforms into phenylpyruvate and other toxic compounds that damage the developing brain. These alternative products often produce the distinctive odors: musty in PKU, sweet in maple syrup urine disease. Third, essential products beyond the block become deficient. The pathway exists for a reason, to create necessary compounds. In glycogen storage diseases, the inability to break down glycogen means no glucose production during fasting. In fatty acid oxidation defects, cells can't generate energy from fat stores when glucose runs low. Classification helps organize these numerous disorders into manageable categories. Small molecule disorders affect amino acids, organic acids, and simple sugars. These typically present acutely with metabolic crises: acidosis, hyperammonemia, hypoglycemia. They're often treatable through dietary restriction or supplementation. Lysosomal storage disorders involve complex molecules that cells can't break down. Material accumulates slowly in lysosomes, causing progressive organ dysfunction. These present later with hepatosplenomegaly, developmental regression, and coarse features. Energy metabolism disorders disrupt ATP production through mitochondrial dysfunction or substrate utilization problems. Organs with high energy demands suffer most: brain, heart, and muscle. These manifest as encephalopathy, cardiomyopathy, and profound weakness during metabolic stress. Phenylketonuria stands as the most common amino acid metabolism disorder and holds historical significance as the first condition detected through newborn screening. With an incidence of 1 in 12,000 births, PKU results from deficiency of phenylalanine hydroxylase, the enzyme that converts phenylalanine to tyrosine. The pathophysiology creates both toxic accumulation and essential deficiency. Phenylalanine builds up and converts to phenylpyruvate and phenylacetate, compounds that damage developing neurons. Meanwhile, tyrosine becomes an essential amino acid since the body can't produce it. This tyrosine deficiency explains the characteristic fair skin and blue eyes. Melanin synthesis requires tyrosine as a precursor. The musty odor provides a diagnostic clue, often described as mousy or barn-like. This distinctive smell comes from phenylacetic acid in urine and sweat. Parents might notice it during diaper changes or when the infant perspires. While not present in every case, this odor combined with fair features in a family with darker complexion should trigger immediate evaluation. Without treatment, developmental delays emerge by 4 to 6 months as phenylalanine metabolites damage the developing brain. Eczematous skin rashes appear frequently, likely from metabolic imbalances affecting skin barrier function. Seizures and behavioral problems follow as toxic compounds accumulate. Treatment requires lifelong dietary phenylalanine restriction, starting immediately upon diagnosis. Special formulas provide necessary nutrients while limiting phenylalanine to amounts the residual enzyme activity can handle. The diet must balance preventing toxicity while providing enough phenylalanine for normal protein synthesis. A narrow therapeutic window requiring frequent monitoring. Early treatment initiated within the first month of life prevents intellectual disability entirely, transforming PKU from a devastating disease to a manageable condition. Maple syrup urine disease attacks rapidly and lethally without prompt recognition. The defect involves branched-chain alpha-keto acid dehydrogenase, blocking metabolism of leucine, isoleucine, and valine. These essential amino acids accumulate along with their toxic metabolites, creating metabolic havoc within hours of protein intake. The sweet maple syrup odor in urine, earwax, and sweat provides the diagnostic hallmark. This burnt sugar smell develops from alpha-keto acids and appears as early as 12 hours after birth. Unlike PKU's musty odor that may be subtle, the maple syrup smell is often pronounced and unmistakable once recognized. Train yourself to identify this odor. It can mean the difference between life and death. Classic presentation begins within 48 hours as breast milk or formula provides the protein load. Initially, infants feed poorly and become increasingly lethargic. The neurological deterioration happens frighteningly fast. Irritability progresses to opisthotonus, seizures, and coma within days. Cerebral edema develops from leucine toxicity, visible on imaging as loss of gray-white differentiation. Emergency management focuses on stopping the toxic cascade. Remove all protein immediately. Switch to protein-free formula or glucose polymers. Correct the metabolic acidosis aggressively with bicarbonate. Most critically, leucine levels above 400 micromoles per liter require hemodialysis. No amount of supportive care removes leucine fast enough to prevent permanent brain damage at these levels. Long-term management demands meticulous dietary control of branched-chain amino acids. Special formulas provide other essential amino acids while limiting leucine, isoleucine, and valine to bare minimum requirements. Even minor illnesses trigger catabolism, releasing branched-chain amino acids from muscle breakdown. Parents need emergency protocols for sick days, including immediate medical evaluation and preventative hospitalization during any metabolic stress. Galactosemia creates a metabolic trap triggered by milk feeding. The enzyme galactose-1-phosphate uridyl transferase normally converts galactose from lactose into glucose. Without it, galactose-1-phosphate accumulates in cells, disrupting multiple organ systems through mechanisms still not fully understood. Presentation follows a predictable timeline after introducing breast milk or formula. Within days, affected infants develop forceful vomiting and watery diarrhea. Parents describe complete feeding intolerance. Every feeding comes back up. Weight loss follows rapidly as nutrition fails and catabolism accelerates. Hepatic dysfunction dominates the clinical picture. The liver enlarges as galactose-1-phosphate accumulates in hepatocytes. Direct hyperbilirubinemia develops, creating the unusual combination of jaundice with vomiting in a newborn. Hypoglycemia occurs paradoxically. Despite consuming a sugar the body cannot use, glucose production fails from hepatic damage. Two complications deserve special emphasis. Cataracts develop from galactidal accumulation in the lens, sometimes visible within the first week. More ominously, these infants have dramatically increased susceptibility to E. coli sepsis. The mechanism remains unclear, but likely involves altered immunity from metabolic dysfunction. Any galactosemic infant with fever needs immediate sepsis evaluation with empiric antibiotics. Treatment seems simple, but carries profound implications. Complete lactose elimination for life. This means no breast milk ever, a devastating message for mothers planning to breastfeed. Soy-based or elemental formulas provide safe alternatives. Even with perfect dietary compliance, long-term complications including learning difficulties and premature ovarian failure occur in many patients. The diet must continue lifelong since galactose appears in many foods beyond dairy products. Legumes, organ meats, and certain fruits contain enough galactose to cause symptoms in sensitive individuals. Urea cycle defects create a toxicologic emergency as ammonia accumulates to brain-damaging levels. The urea cycle normally converts ammonia from protein metabolism into harmless urophoric excretion. When any of the 6 enzymes fail, ammonia levels skyrocket, causing irreversible neurological damage within hours. Hyperammonemia above 150 micromoles per liter in neonates signals urea cycle dysfunction. Normal newborn levels stay below 100, even during illness. The presentation follows protein loading, typically 24 to 72 hours after initiating feeds. Poor feeding progresses to vomiting and lethargy as ammonia affects the brain. Without intervention, seizures and coma follow rapidly. The respiratory pattern provides a crucial diagnostic clue. These infants hyperventilate, creating respiratory alkalosis, increased pH with low CO2. This differs completely from metabolic acidosis seen in organic acidemias. The hyperventilation results from direct ammonia stimulation of the respiratory center. Finding respiratory alkalosis in a lethargic newborn should immediately trigger ammonia measurement. Emergency treatment cannot wait for specific enzyme identification. Stop all protein intake immediately. Switch to glucose-based nutrition. Despite the alkalosis, correct any metabolic acidosis component from poor perfusion. The critical decision point comes with ammonia levels. Above 400 micromoles per liter, immediate hemodialysis becomes life-saving. No medical therapy clears ammonia fast enough at these levels to prevent permanent brain damage. Specific ammonia scavengers work through alternative excretion pathways. Sodium benzoate conjugates with glycine to form hippurate. Sodium phenylacetate combines with glutamine to create phenylacetylglutamine. Both compounds contain nitrogen and exit through the kidneys, bypassing the blocked urea cycle. Loading doses followed by continuous infusions maintain ammonia removal while arranging definitive treatment. Long-term management requires protein restriction with essential amino acid supplementation, creating a delicate balance between preventing hyperammonemia and ensuring adequate growth. Fatty acid oxidation disorders reveal themselves during metabolic stress when the body attempts to use fat for energy. These enzymes normally break down fatty acids into acetyl-CoA for energy production. When blocked, cells starve for energy despite adequate fat stores, like having a full gas tank but no working fuel pump. The cardinal finding is hypoglycemia without ketosis. This combination should immediately alert you to fatty acid oxidation defects. Normal fasting produces ketones as the liver converts fatty acids to alternative fuel. These infants cannot mobilize fatty acids, so no substrate exists for ketone production. Glucose disappears without the expected metabolic compensation. Timing follows predictable patterns. Newborns tolerate short feeding intervals, but any prolonged fasting triggers decompensation. Common scenarios include delayed feeding after delivery, intercurrent illness reducing intake, or simply sleeping through a night feeding. The infant who was fine at the 2 a.m. feeding presents critically ill by morning rounds. Multi-organ involvement reflects widespread energy failure. Cardiomyopathy develops as the heart, which preferentially uses fatty acids for energy, cannot meet metabolic demands. Liver dysfunction manifests as elevated transaminases and hyperammonemia from secondary effects. Rhabdomyolysis releases creatine kinase as muscle cells die from energy depletion. The combination of hypoglycemia, cardiac dysfunction, and muscle breakdown in a previously well infant strongly suggests fatty acid oxidation defects. Prevention focuses on avoiding fasting states. Frequent feeding schedules prevent fatty acid mobilization. During illness, maintain glucose intake through IV dextrose if oral feeding decreases. Medium-chain triglyceride supplements bypass long-chain fatty acid oxidation defects since MCTs enter mitochondria without carnitine transport. Emergency protocols emphasizing glucose provision during any stress prevent most crises. Parents need clear instructions about maximum fasting times based on age and specific enzyme deficiency. Ambiguous genitalia represents a medical and social emergency requiring immediate systematic evaluation. Beyond the obvious anatomical concerns, life-threatening metabolic conditions like congenital adrenal hyperplasia may underlie the presentation. Every infant with atypical genitalia needs urgent assessment for potential salt-wasting crisis. Physical examination provides critical initial information. Palpable gonads in the labioscrotal folds suggest 46XY DSD, since ovaries don't descend. Their absence doesn't confirm 46XX status, but makes it more likely. Assess the degree of virilization systematically. phallus size, location of urethral opening, labioscrotal fusion, and any palpable Müllerian structures. Document findings precisely using standardized terminology. Laboratory evaluation must proceed urgently. Send karyotype immediately, but don't await results before starting other tests. Electrolytes identify the salt-wasting pattern of CAH. 17-hydroxyprogesterone levels confirm the diagnosis in most cases. Order these stats. CAH represents the most common cause of ambiguous genitalia and requires immediate treatment to prevent cardiovascular collapse. The approach to gender assignment has evolved significantly. Current practice bases decisions on functional potential rather than chromosomes or appearance alone. Which anatomical configuration will provide the best sexual function, fertility potential, and psychological outcomes? This complex decision requires input from pediatric endocrinology, urology, genetics, and psychology. Communication with families demands exceptional sensitivity. Avoid assigning gender pronouns until the team makes recommendations. Explain that additional testing will clarify the situation. Emphasize that the baby's health takes priority. Some conditions require immediate treatment regardless of anatomical considerations. Provide support resources and ensure families understand this represents a variation in development, not a defect or mistake. The multidisciplinary team approach ensures comprehensive care, addressing medical, surgical, and psychosocial needs throughout childhood and beyond. These emergency patterns demand immediate recognition and action. Salt-wasting CAH presents with the triad of low sodium, high potassium, and hypoglycemia. Start hydrocortisone immediately. Hyperinsulinism reveals itself through glucose requirements exceeding 10 milligrams per kilogram per minute, despite appropriate management. Galactosemia uniquely predisposes to E. coli sepsis. Any jaundiced infant with positive blood cultures needs galactose restriction pending confirmation. The sweet odor of maple syrup urine disease, combined with seizures and ketoacidosis, requires immediate protein restriction and often dialysis. Urea cycle defects create the unusual combination of hyperammonemia with respiratory alkalosis rather than acidosis. This pattern is pathognomonic. Neonatal thyroid storm, though rare, presents as tachycardia with heart failure in infants of mothers with Graves' disease. These babies need urgent antithyroid therapy and beta blockade. This framework guides rapid clinical assessment. First, determine if hypoglycemia is transient or persistent. This distinction drives your entire workup. Check if electrolytes match the CAH pattern. Examine for ambiguous genitalia, which, combined with electrolyte changes, confirms CAH. Notice any distinctive odors during examination. Check ammonia in any encephalopathic infant, looking specifically for respiratory alkalosis. Consider multiple hormone deficiencies when findings cluster: hypoglycemia with micropenis, cholestasis with hypothyroidism. Finally, reassess if standard treatments fail. Poor response suggests you're missing the underlying diagnosis. Focus your studying on these high-yield facts. CAH appears most frequently. Know the electrolyte pattern cold. CAH also causes most ambiguous genitalia cases. Congenital hypothyroidism remains the most preventable cause of intellectual disability worldwide. Master the critical sample technique for hypoglycemia workup. Recognize prolonged jaundice as a thyroid red flag. Remember, hypophosphatemia, not calcium deficiency, drives rickets in premature infants. For IDMs, hypoglycemia management takes priority over other complications. Neonatal endocrine disorders share common themes. Early recognition prevents permanent sequelae, whether intellectual disability from hypothyroidism or death from CAH crisis. Many present with non-specific symptoms, requiring pattern recognition for diagnosis. Newborn screening revolutionized outcomes, but doesn't catch everything. Clinical vigilance remains essential. Electrolyte patterns often provide the diagnosis faster than specialized tests. Persistent hypoglycemia always indicates pathology requiring systematic evaluation. Success requires integrating laboratory values with clinical patterns. The infant with ambiguous genitalia needs immediate electrolyte assessment. The hypoglycemic baby needs a critical sample. The jaundiced infant needs thyroid evaluation. Master these associations for both clinical practice and certification success. A 10-day-old female infant presents with vomiting, dehydration, and lethargy. Physical examination reveals hyperpigmentation of the nipples and labia. Laboratory studies show sodium 125, potassium 7.2, and glucose 42. What is the most appropriate initial treatment? Fluid bolus with D10W20 hydrocortisone 100 per day IV. Oral fludrocortisone 0.1 mg daily. The correct choice is hydrocortisone 100 mg per meter squared part per day IV. This question is testing your knowledge of congenital adrenal hyperplasia, CAH, presentation, and emergency management. Hydrocortisone 100 mg per meter squared part per day IV is the appropriate emergency treatment for salt-wasting CAH, which this infant clearly has, based on the characteristic presentation of hyponatremia, hyperkalemia, hypoglycemia, and genital hyperpigmentation. Fluid bolus with D10W is incorrect because while fluid resuscitation and glucose are needed, glucocorticoid replacement must be initiated first to address the underlying hormonal deficiency. Oral fludrocortisone is incorrect because in an acute crisis, IV hydrocortisone is required first. Mineralocorticoid replacement with fludrocortisone would be added later as part of maintenance therapy. A 3-day-old term infant develops poor feeding, lethargy, and a sweet maple-like odor. Laboratory evaluation reveals elevated branched-chain amino acids, particularly allo-isoleucine. What is the most appropriate nutritional management? Diet low in branched-chain amino acids, diet low in phenylalanine, high-protein formula. The correct choice is diet low in branched-chain amino acids. This question is testing your knowledge of maple syrup urine disease diagnosis and management. Diet low in branched-chain amino acids is correct because MSUD is caused by an inability to metabolize the branched-chain amino acids, leucine, isoleucine, and valine. The characteristic sweet odor and elevated allo-isoleucine are pathognomonic for MSUD. Diet low in phenylalanine is incorrect because that's the treatment for phenylketonuria, not MSUD. High protein formula is incorrect because it would increase the intake of all amino acids, including branched-chain amino acids, and worsen the condition. A 2-week-old infant presents with prolonged jaundice, constipation, and poor feeding. Newborn screening shows T4 less than 6 and TSH greater than 50. What is the appropriate initial medication dosage? Levothyroxine 5, 10 to 15, or 25. The correct choice is levothyroxine 10 to 15. This question is testing your knowledge of congenital hypothyroidism treatment dosing. Levothyroxine 10 to 15 is the standard initial treatment dose for congenital hypothyroidism. The goal is to normalize T4 levels rapidly, within 2 weeks, to prevent neurodevelopmental complications. Levothyroxine 5 is incorrect because it's too low and would not achieve rapid normalization of thyroid hormone levels. Levothyroxine 25 is incorrect because it's excessive and could cause thyrotoxicosis. A term neonate presents with seizures and lethargy at 36 hours of life. Laboratory findings include serum sodium 122, high urine osmolality, and high urine sodium. The infant had perinatal asphyxia requiring resuscitation. Which condition is most likely present? Diabetes insipidus, renal tubular acidosis, syndrome of inappropriate ADH secretion. The correct choice is syndrome of inappropriate ADH secretion. This question is testing your knowledge of fluid electrolyte disorders following perinatal asphyxia. SIADH is correct because the clinical presentation includes hyponatremia with inappropriately concentrated urine, high osmolality, and high urine sodium typical of SIADH. Perinatal asphyxia is a common cause of SIADH in neonates. Diabetes insipidus is incorrect because it presents with hypernatremia and dilute urine, low osmolality. Renal tubular acidosis is incorrect because while it can cause electrolyte abnormalities, it primarily presents with metabolic acidosis and would not typically cause hyponatremia with concentrated urine. A term neonate develops jaundice and mild anemia on day 3 of life. The infant has no hemolysis on peripheral smear. Laboratory studies show total bilirubin 18 with direct fraction 0.8, positive blood culture for E. coli, and normal lactate levels. What is the most likely diagnosis? Biliary atresia, galactosemia, sepsis without metabolic disorder? The correct choice is galactosemia. This question is testing your recognition of the lactosemia presentation with E. coli sepsis. Galactosemia is correct because the combination of jaundice, E. coli sepsis, and elevated bilirubin in a neonate who has started milk feeding is classic for galactosemia. Infants with galactosemia have increased susceptibility to E. coli sepsis due to impaired neutrophil function. Biliary atresia is incorrect because the direct bilirubin fraction is not significantly elevated, as would be expected with biliary atresia. Sepsis without metabolic disorder is incorrect because the association of E. coli sepsis with jaundice in a term neonate strongly suggests galactosemia as the underlying cause, rather than simple sepsis.